Welcome back to the Hand to Shoulder Solution, giving pain the middle finger. I'm your host, Petitto. I'm an occupational therapist and a board-certified hand therapist. I specialize in the rehabilitation of orthopedic conditions of the hand through the shoulder. Basically, anything that's causing pain, anything that has to do with the musculoskeletal system, the bones, the ligaments which connect bone to bone, the tendons which connect muscle to bone, the muscles themselves, and also the nerves and the skin. I've been practicing since 2000. People say, hey, what's with the pinstripe suit? You know what? I've been practicing for over 20 years. That means I've earned my stripes. I want to mention why I'm bringing you this podcast, is because I want you to understand the fundamentals of how your body works and to recognize what your body needs so that you can obtain what you need when you need it. In healthcare in general, the service that you obtain and the timing when you receive it is very important for a good outcome. What this is not treatment or advice. This is information sharing so that you may be empowered to make decisions for yourself in accordance with your healthcare provider, your doctor, your therapist, other professionals who are helping you take care of your problem. It's really important that you receive a very thorough examination, a very thorough evaluation, because every condition is different, every person is different. Therefore, every condition within every person is different. And even when it's within the same person, it could be, it's going to be presenting differently on the right side versus the left, and vice versa. So today, let's talk about arthritis at the base of the thumb, and let's talk about the surgical approach to arthritis at the base of the thumb. And it's important that the hand therapist understands what the hand surgeon does, because the hand therapist needs to know how to rehabilitate that and make sure that everything heals appropriately. No damage is done to the surgery site. So there's a protective phase, and then early on, we have to start moving it very gently in pain-free range of motion. Movement is really the primary way the body gets blood flow to all surrounding structures. Muscles contracting and relaxing and squashing fluids around. The movement of even the joints themselves helps to move blood through the vessels. With almost every condition, studies have proven that earlier movement is always better. Years ago, when a joint replacement would be done at the base of the thumb, the patient would be put into a cast for about 6 weeks. Then that was a much more difficult rehab because the patient would be very, very stiff. Sometimes, if you contrast that to full immobilization with a cast versus use of a custom splint, for example, and removing the splint a few times a day to do some light range of motion appropriately, then we get better healing and quicker healing and overall a much better outcome. So let's review anatomy, all right? And you probably have seen it on some previous episodes. When you look at the base of the thumb, that's an area that allows us to move our thumb in so many different directions. And that, because of that, the price we pay is more wear and tear. The base of the thumb is called a saddle joint. It's like two horses' saddles. If you put them perpendicular to each other, the saddle would move this way and it moves this way. And the base of the thumb is made up of the first metacarpal, that long thumb bone, the first thumb bone you come to when you feel past your wrist. The base of the thumb, there's one of the carpal bones. We talked about the carpal tunnel in an earlier episode, made up of the 8 carpal bones. And within the wrist in general, there's 15 bones involved. We have the radius, the ulna, the 8 carpals, then the 5 metacarpals. If you look at the back of your hand, you see those are the 5 metacarpals back here. So if we go on the first metacarpal of the thumb, when you go to the base of that and you feel the bottom of it, if you bend your thumb down and you feel the base, you follow that bone down and you feel the end, it's going to rise up a little bit, and then you drop off a little cliff, and now you're right on the trapezium bone, and that is where that saddle joint is, at the base of the thumb and trapezium. That's That's the joint surface. All right. Now, what happens is this gets worn so significantly that bone spurs form, and also the joint subluxes or just kind of slips out of joint a little bit. The base of that first metacarpal right here kicks out a little. So if you are having a lot of pain at the base of your thumb and you look at the base of your thumb and you see this rising up, it'll kind of look like a shoulder. If it was a tiny person, it would look like a shoulder. And we call that shoulder sign, because what's happening is this bone is sliding off the end of that trapezium, the small carpal bone, and that's coming up, making a shoulder sign. So in my clinical notes, in my observation piece, I'll note that I observe a shoulder sign, and then I want to palpate this area, see if it's tender. Often bone spurs form around the edge, and like we were talking about previously, bone spurs are forming because the body is trying to fuse the joint to stop bone from rubbing on bone. We call it degeneration. Just the joint degenerates. It's from osteoarthritis. Itis means inflammation. Osteo means joint. So osteoarthritis is the arthritis from wear and tear. And our bodies are designed to last optimally for about 40 years. And then things start to wear out, which is normal. And of course, it depends. What has the person been doing for work their whole life? Are they predisposed to arthritis because hereditary factors? It's a long list. But we were talking about this joint degenerating. Sometimes it gets to the point where, like a knee. If a patient, finally says, this hurts so bad, no matter what I try, it hurts, and it's worn out so much, I need something done, and that's the time to have surgery, because you don't want to race to surgery immediately, because we still have to use our thumb for the rest of our life. So the longer we can wait, the better, because wear and tear affects everything, even the thumb after surgery as well. So let's talk about surgical techniques. I attended an annual meeting for therapists, which discusses the therapy postoperatively and for patients without surgery on all the specialty area, the fingers through the shoulder. I also attend the American Society for Surgery of the Hand annual meeting to learn about what are the latest techniques that folks are doing, that surgeons are doing to treat this condition. There's an old way of treating it that I used to rehab 15 years ago or so, and they would actually create a concave surface on each bone and then put a ceramic ball in there. That was a difficult rehab. Most patients did pretty well, but it was very difficult. We have better outcomes nowadays with the Europeans are using a two-piece ball and socket set, where they would put the socket on this small trapezium bone, and then the ball would have it would be attached to a shaft that would go up the center of this bone. Another technique which is used pretty frequently in the United States is it's termed the anchovy procedure, where the surgeon would harvest a tendon from a muscle that the patient doesn't really need. There's one in the wrist called palmaris longus, and you can touch your thumb to your small finger and then resist yourself from bending toward your palm and see if that tendon pops up. You can see it on me. You can see that pop up pretty good. So not everyone has a palmaris longus, so that's a test for it. I have one, so I'm glad it's there. Someday, if I need that pulled out and folded up and put in there to replace the joint, then that can be done. So let's talk about that for a minute. When you take out that tendon of that, you remember tendons connect muscle to bone. When you take out that tendon, it could be folded up and made into a mattress, and that is put in place of the trapezium bone. So now, instead of bone on bone, what you have is bone on nice soft tendon, and then that scars in and gets nice and rubbery. There's another technique which I am seeing more often now. It's actually the most often out of all the techniques. it's called a suspension plasty. And what is done here is the trapezium bone is taken out, and there's a nice kind of flat little rope. It's like a tape, but it's a really nice high-end nylon composite material that a drill hole is made through the bone, and that rope is placed underneath the first metacarpal, and it goes into the second metacarpal, and that supports this, and the trapezium bone is removed. So that gets removed. Now picture a big hole here, an empty space. There's a cable that goes underneath and prevents that first metacarpal bone from sliding down into the hole. And then the hole fills in with nice scar tissue, nice rubbery material. It's a relatively easy therapy. The therapy, and here's what to expect after a surgery like that. Basically, any of the techniques used is initially, I'll see the patient about 5 days after surgery. I'll remove the postoperative dressings, do wound care if any wound care needs to be done, address the wound, and then I'll fabricate a nice custom thermoplastic orthosis that would fit perfectly on the patient. I would bubble up this area so nothing is touching that base of the thumb. They nice Velcro straps. We put some padding in here. It's some moleskin, molded exactly to the patient, so it's providing absolutely perfect stability while at the same time not touching any of the surgery site. Usually, the second we put that on, and the patient really feels significant relief from being in the postoperative dressings, which can get tight a little bit because now you're getting some postoperative swelling. That's one of the reasons why I see patients about 5 days after surgery is I can get off those compressive dressings, put them in the custom orthosis, educate the patient to continuous elevation. I tell them when you're up and walking, just bend your elbow. A lot of people like to just lay their hand on the chest, but walking with the hand down by their side, there's all that centripetal force that just throws fluid down into the hand and makes it swell up a lot, makes it throb. And we want to get that swelling out of there. And swelling is normal. So everyone should expect to have a certain amount of what I call appropriate swelling. The lymphatic system sends the fluid there. When you get a burn, you get a blister, that's lymph fluid. The lymphatic system is sending swelling to that area, and it's actually circulating the fluid. It's a really important part of the immune system, and it carries away bacteria. So that there's one stage of wound healing is the inflammatory phase, which can last up to a couple of weeks. So, we don't want to really suppress the body's natural systems very much, but it should be monitored and steps should be taken so that we don't get excessive swelling, leading to excessive pain, leading to, down the rabbit hole of more inflammation, and now it's going to be harder to get it moving, et cetera. So we want to really want to coach it along properly. Now, we would start nice active range of motion with turning the forearm, because remember when you turn your hand palm up, the radius is now parallel with the ulna. When you turn it palm down, the radius flips over the top of the ulna. So that's a little bit of action at the wrist. Doesn't directly affect the thumb very much. So we can start with just bending the elbow and turning a palm up, straightening the elbow and turning a palm down, which puts less stresses on the area. And then hand over the head, closing and opening the index, long, ring, and small fingers, leaving the thumb totally relaxed. And then the tendons that connect the bones of the fingers to the muscles in the forearm, they're gliding through the carpal tunnel, and they're moving fluids around a little bit. But again, we're still not aggravating the surgery site. And so we follow the protocols that we follow, which I like the most, or I feel that are the gold standard. It's from the Indiana Hand Center. The Indiana Hand Center protocols, I feel are excellent. But a protocol is a rough guide because, again, every patient's different. So it might say, at 4 weeks do this, at 6 weeks do that. It's not an exact map, and that's any therapist listening. They'll agree that if a patient is having a tough time. Maybe they have more inflammation than normal, or maybe, you know, anything of a multitude of things is going on. They might have to slow down their protocol a little bit. The opposite can also be true. They might have to speed up the protocol a little bit. Say, wow, you're scarring down quickly. It's getting stiff really, really quickly. All right, so within the limits of safety, let's speed up the protocol. So that's called clinical reasoning. So every day the patient comes in, which for this would be at the most 2 times per week. It's typically 2 times per week for the first couple of weeks. Then I move them out to once a week. So every day the patient comes in, I'm reassessing and say, what does it look like now? What's it doing? How's it responding to what we're doing? Okay, let's make some changes to the home exercise program. Let's make changes to what we do in the clinic. And by the way, if I have a patient coming into the clinic, it's because I have to do something for them that they can't do for themselves at home. Or I need to get eyes on it and make sure there's no sign of infection. We don't have excessive swelling. It's, things are going along well. Does anything need to be adjusted? All right. So that's some of the basics of surgical techniques. Now, how long does it take to get rehabilitated after a joint replacement at the base of the thumb? 8 to 12 weeks. So that doesn't mean coming into therapy for 12 weeks. What that means is the first couple of weeks, twice a week, maybe the first 2 or 3 weeks, depending on how the patient's responding. And then after that, once a week, probably for another 4 to 6 weeks. So, 6 to 10 visits. And then I will follow up with somebody every couple of weeks. And then once we get into strengthening and, some more things that patients can do on their own at home. And I would basically, at that point, I'm just serving as a coach. I was like, okay, let's change things up a little bit. Let's optimize in this way. Now, the base of the thumb after surgery, it's not going to be 100% solid until about 12 months after. But 12 weeks, the patient's able to do all their daily activities. They're able to use their hand normally. But, I want to have them go out and, stack 10 cords of firewood or something. We would still be a little bit cautious. And also, one other thing is that I always tell patients after the surgery, the thumb now is going to be a little more oriented toward the palm. It's not going to be totally flat when you lay your hand flat on the table. So if anybody's going through this right now and they're having, they're in therapy for that, and you might feel, tempted to press your hand flat on the table, but you don't want to do that because it's not going to be exactly the same as the other side. And that's a good thing because now it's positioned in a healthier position. It's going to prevent excessive, wrong types of, stresses. So it's okay. It's not going to get in your way of anything, but just have an awareness of that. All right. Speaking of awareness, and speaking of significant degenerative osteoarthritis, and this is a lot of information. If you want to contact me, if you want to write some comments, I would like to come into the studio with a list of questions and then answer questions. So if you're thinking about having this done, if you're worried about therapy afterwards, and there is a lot of apprehension. I think there's a lot of misconceptions out there about therapy. Is that, it has to hurt? It's gonna be aggressive. And no, none of that. We want. My job as a hand therapist is to really facilitate optimal healing, and not cause pain, not cause extra inflammation and swelling. So it should be, me with my patients, it's a close working relationship. It's a close teamwork. And as long as a person is doing what they should do at home, which by the way isn't very much, home program performed 3 or 4 times a day. And when you do your home program, it should take probably 4 minutes, 5 minutes. So pretty easy, and just making good habits. Now, back to severe degenerative osteoarthritis. I want folks to have an understanding that there are some other techniques for the rest of the wrist. So there's a lot of degenerative diseases that occur which really affects the mechanics of all of these carpal bones. And they can start to crack and collapse, and then the ligaments give free, and there's many different conditions of the wrist, which I would like to talk about later on future episodes. There's one thing that can be done to stop wear and tear. And remember, the body is wanting to fuse the joints together. When the body's sending out bone spurs, it wants to fuse the joints together so there's no more movement. So one treatment is fusion. So to fuse these together, I've had patients who've had plate and screws placed through the third metacarpal, the long finger metacarpal, down through here and onto the radius to stop the wrist from moving. The other joints can take over to properly position the hand. It's a little bit of an inconvenience initially, but that allows the joints to fully fuse, and pain decreases and pretty much stops, because now they're just not rubbing bone on bone anymore. There's also some arthroplasty, or arthroplasty just means joint replacement. So there's a hemiarthroplasty technique. This is the Journal of Hand Surgery. I subscribe to this. I really like looking at the studies. I like looking at all of the updated information. There's one small area of a joint replacement that can be done in the center of the wrist, and then you see how this is large. This is the bone. The bright white portion is the implant, and then you have sort of a ball and socket type situation. Range of motion is a little decreased after something like this, but range of motion is what we call within functional limits, meaning you wouldn't notice a big hindrance to your performance of your functional activities. You'll have enough movement to use your hand and arm effectively without really noticing a difference. Of course, it's not going to be 100% like it was, when you were younger and you didn't have those joint problems. The big thing is, again, this goes back to the pain, to where now the person had so much degeneration at the joint where now something has to be done. So these are what we call salvage procedures. So we want to salvage as much function as we possibly can. We want, and I say we, because the surgeon and the therapist has to work hand in hand, has to work very closely to have a good outcome, because, you can have a perfect surgery, but if the therapy isn't what it should be, or if the timing is, if the therapy isn't what it should be, the outcome isn't going to be what it should be, frankly. Now, I want to talk about scar care, and we can talk a little bit more in depth at a later episode. But where a lot of people go wrong is they'll be very aggressive with massaging the scar. I really want to stress that scars develop over a period of about 2 years. The first 8 months are most important. But you see, it takes a significant amount of time for the scar to flatten out and desensitize and not be as red. If you look at your normal skin under the microscope, all the cells lie nice and flat and parallel. When scar forms, the cells lie crisscross and get lumpy. With deep pressure, you can reorient the cells and literally flatten out the scar. But where people go wrong is they get too aggressive. They do it too often. I tell people, just, once that solid scar is there, it's after about, it's been 4 weeks, it's been 5 weeks, 6 weeks. I have my patients get the vitamin E gel tabs that they swallow as a supplement, snip off the end with the scissors or poke it with a pin, and just put a couple of drops of oil, smear it on there, and let it soak in once or twice a day. That's what they do. And then once it's healed up enough to be able to take a little bit of light pressure over that surgery area, because again, we don't want to put pressure on the surgery area if it's too soon. But once it's time, once your therapist says, it's time to do that, I just have people massage very gently, or even just lay their finger over for just light, steady pressure for about 2 minutes, a couple times a day. If it's light scar massage, and again, light, not deep pressure, light scar massage with the vitamin E oil, that should be done, in my opinion, twice a day for about 1 or 2 minutes and not more. It's easy to make it a habit and just kind of sit there and rub it all the time. And those are the people who come in with hypersensitivity and it's red, it is irritated. I've had people come in the office and they're having, they had surgery, they had therapy elsewhere and other places where we told them, rub that scar. You got to rub it several times a day. You got to put a lot of pressure through that. And they come in and it's red and it's inflamed, it's raised up. I'll tell them to just put it under cold running water, only until it's deeply cold, 10 or 20 seconds, leave it alone, stop massaging it. The scar is going to mature over a period of 2 years. Come back next week. They come back next week, pain is gone, the hypersensitivity is almost fully reduced. Another nice way to treat scars is to use a gel sheet. And I lie a gel sheet over the top of the scar, wrap it very lightly with some compressive wrap. I thought I had my gel sheet right here. It's not here. Somebody came in the night and installed it. And I would just lightly lie a compressive wrap over the top of that scar with a gel sheet, and they would sleep with that. And over the night, it just lightly, very softly flattens that scar and also has a nice desensitizing effect as well. When the scar is more mature, I like to use a piece of Dyson material. It's a blue square. It's sort of like a non-slip shelf paper that that grips the surface of the skin, so it doesn't require any deep pressure. And I have the patients do a light stretch for 10 seconds, this way, and then this way, and then this way, and then that way, 10 seconds each direction, a couple of times a day. That prevents the scar from sticking to underlying structures, which, by the way, that's another problem with scars, is they like to stick to underlying structures. So if the underlying structures is, let's say, a tendon that connects the muscle to the bone, and the one that picks, you can see the tendons on my wrist pretty good. So when you pick that up, that tendon has to glide underneath the skin because it's attached to the muscle up here. So that muscle contracts, has to pull it up. And if that rope is not sliding under the skin, or the tendon is not sliding under the skin, and it's stuck in the scar, that's not good. It'll stop your movement. And that area is very forgiving. Scar tissue can also be stretched out, so it typically is not a problem. That's a little bit about scar. We can talk more about that at another episode. I want to also mention about what kind of splints do we need? What kind of external support does the patient need after joint replacement at the base of the thumb? So we did talk about this forearm-based thumb spica orthosis. After about 4 weeks post-operative, 4 to 5 weeks, depending on the patient, I'll remove the forearm portion and just turn that into a hand thumb orthosis, where the thumb is still supported, but now the wrist is left free. And more often than not, instead of continuing with the plastic orthosis, I'll just go to a neoprene, nice soft, just like wetsuit material orthosis or brace rather, over the counter, that the patient would wear during waking hours for some support that would support the base of the thumb. And then during sleeping hours, they would still wear the plastic brace. And that would continue until about 6 to 8 weeks post-operative, and maybe some sort of external support, probably with something like this, for another 4 weeks or so for relatively heavier activities. So, the old saying is, the second you put a patient in a brace or a splint or arthrosis, the second you put them into that, you start weaning them out of that because, again, stiffness sets in so quickly, other problems set in quickly, but the balance lies, and we have to protect it, let it heal. But as soon as the patient's able, we start stepping away from the brace. Okay, so that's the base of the thumb. We're going to talk about some other fun things in future episodes, and I'm looking forward to it. I appreciate you tuning in. I want to dedicate the show to Jesus Christ, who continuously guides me to do right, to do well, and to continuously improve. My wonderful wife, who continuously encourages me to follow my dreams. To my wonderful family, my teachers, and the community who raised me and taught me my values. For me, learning is humbling. The more I learn, the more I realize how much there is yet to learn. It just continues to open doors for more learning. Thank you.